Hello everyone. I'm excited to have some discussions on the classic presentations of common diseases. So let's make some stories to explain the classic symptoms associated with those classic diseases. So the first one we have is the Budd Chiari syndrome, um, which is actually obstruction of your hepatic vein. So whenever you have obstruction of your hepatic vein, it leads to pooling of blood inside your liver. And if the blood pools up inside the liver gets bigger, so you have hepatomegaly. And the liver capsule, which is also known as Gleason's capsule, this capsule is in high tension if you have a high amount of blood pooling in the liver. So this produces abdominal pain. And as you are pulling blood in the liver, the portal system cannot empty itself into the liver, so the portal venous pressure also increases. So ultimately you have a raised hydrostatic pressure in the vascular system of the abdomen. This leads to transudation of the fluid from inside the vascular space out to the extracellular space, which leads to development of acids. Pretty simple. And another point is, whenever you have Budd Chiari syndrome, you have to search for a specific reason because it doesn't happen idiopathically. There is some causes like polycythemia vera. You can have antiphospholipid antibody syndrome or any procoagulant state like factor V Leiden mutation can also lead to this Budd Chiari syndrome, which is less common. Okay, so this is the first one we have covered. Next one, let's cover the Clostridium difficile infection. So let's make a story. So the story goes like this. Whenever someone is treated with broad spectrum antibiotics like penicillins, cephalosporins, clindamycin, for any particular reason, if they are treated for a long enough time, this antibiotic sometimes leads to severe depletion of the microbial flora inside the gut, especially the colonic flora, because colon is loaded with a lot of bacteria, gram positives, negatives, anaerobes, a lot of them. And if you use a broad spectrum antibiotic, the amount of normal bacterial flora will be severely depleted, and that is actually a chance for the pathogenic bacteria to take over that place, and one of them is Clostridium difficile. So Clostridium difficile sees the opportunity of taking up the place which is vacant now, and it starts to grow up, and it actually fills up a part of colon, and it starts to release its pathogenic toxins, which are called enterotoxin A, cytotoxin B. And those toxins inhibit something called a Rho regulatory protein. And if the Rho regulatory proteins are inhibited, there is actually disruption of the actin cytoskeletal structure in the intestinal cells or enterocytes. And if there is disruption of the intestinal actin cytoskeletal structure, the tight junctions that hold the intestinal cells or enterocytes in close and tight proximity, those tight junction tends to become looser and looser, and sometimes they are completely disrupted. So now you have some spaces in between cell through which the fluid starts to leak into the intestine. So you will have development of diarrhea. And another thing is, whenever you have those cytotoxin and enterotoxin coming inside the cell or inside the enterocyte, they tend to damage the enterocyte, and this damage of enterocyte will invite the leukocytes to come in. So the leukocytes come in, there is formation of an inflammatory focus, so there is ongoing inflammation, and whenever you have inflammation, you will have pain, right? So the patient also have pain, abdominal pain, and this inflammation leads to formation of something called a pseudomembrane, which is simply an exudate, a thick exudate containing fibrin, containing coagulated proteins, and even containing dead cells like dead neutrophil, dead enterocytes. All of those structures lead to formation of those grayish white pseudomembranes, which you can actually see if you do a colonoscopy in those patients. And as there is an inflammatory process going on in an intestine or colon, the patients will typically also develop leukocytosis. Clear? Nothing, no confusion, very clear. Okay, so next disease we are going to cover is familial hypercholesterolemia. So the most common reason for familial hypercholesterolemia is decrease level of LDL receptor signaling, which might occur due to decreased level of LDL receptor itself, or decreased sensitivity of LDL receptor, or decreased post receptor mechanism. So decreased LDL receptor signaling is a broad term for a variety of reasons. And though LDL receptors are commonly found in peripheral tissues, but most importantly in the liver, so the LDL cannot dump the cholesterol inside itself into the liver. So if it cannot dump the cholesterol inside the liver, now the cholesterol level in the blood starts to get higher and higher, because one of the major constituent of LDL is cholesterol. And this cholesterol, now as the level is rising higher and higher, this tend to deposit in various sites of your body. So it can deposit under your skin, causing skin xanthoma, xanthelasma, and it can deposit under your skin, and even deposit in Achilles tendon or different tendons. So one of them is Achilles tendon. So that will be called a xanthoma, or Achilles tendon xanthoma, which occurs due to increased level of cholesterol inside your serum, leading to deposition of cholesterol inside the tissues like Achilles tendon. So this is actually classic feature. So whenever you see Achilles tendon xanthoma, the initial knee-jerk response will be, yeah, you have to think about familial hypercholesterolemia. Another point, familial hypercholesterolemia is a very bad disease. It's also known as type 2 dyslipidemia, and it's commonly associated with an earlier onset of cardiovascular and neurologic diseases, or any vascular event. So there is an increased chance of getting occlusive thrombus, occlusive atherosclerotic disease in earlier age whenever someone has familial hypercholesterolemia. Okay, remember that. Next one we have Waterhouse friedrichson syndrome. Okay, so Waterhouse friedrichson syndrome is a catastrophic situation. So whenever someone, like some kid, like who is about 15 to 25 years age, who is sexually active, or who lives in a dorm, so commonly dorm, or who is in military service, living in a military dorm, or any close contact. So whenever someone is living in a close contact spaces, they tend to get colonized. Their respiratory mucosa, especially the upper respiratory mucosa, tends to get colonized with meningococcus, which is Neisseria meningitidis. And Neisseria meningitidis actually contains this capsule, the polysaccharide capsule, in the outer side of its surface, and this polysaccharide capsule actually helps it to evade the host immune response, especially evade the neutrophil mediated phagocytosis, because this is kind of a slippery object. So this bacteria, whenever they get this polysaccharide capsule, it's kind of a slippery thing, and neutrophil macrophage cannot actually hold them tight unless they are opsonized. So this Neisseria meningitidis now crosses the respiratory epithelium, goes into the blood, causes bacteremia, and then it goes into the meninges, causing meningitis. And in the blood, it causes bacteremia. And one of the target organ that it can go is one of the important targets that it can actually damage is endothelium. So meningococcus can damage endothelium, and if you damage endothelium, this will lead to activation of the coagulation cascade. And the endothelial damage in meningococcal disease is widespread. So you will develop a severe widespread coagulative disease, which is simply DIC, disseminated intravascular coagulation. So you will chew up all the clotting factor in the DIC thrombosis, so there will be bleeding, because you have chewed up all the clotting factors. Now there is no clotting factor to protect you from bleeding, so those patient gets bleeding, and the bleeding can be under the skin, forming rashes. The bleeding can be inside the organs, and one of the common organ is adrenal gland. So whenever you have bleeding in adrenal gland, this will lead to adrenal insufficiency, especially when the bleeding or hemorrhage is bilateral. So you will have an acute adrenal insufficiency, and that's the Waterhouse-Friedrichsen syndrome. And as you can see here, this starts with DIC, and whenever you have DIC, there is consumption of the clotting factor leading to adrenal hemorrhage. And if you have adrenal hemorrhage, you will have acute Addison's disease, thing like that. It's kind of acute Addison's disease or something like that. So this will lead to a sudden decrease in the level of all the steroid hormones that are released from especially the adrenal cortex and also in the adrenal medulla. So you will not have catecholamines from the adrenal medulla. You will not have the outer surface like mineralocorticoids, cortisol. So all of those will lead to hypotension, and the patient typically, if they are in severe hypotension, it will lead to death actually. Okay, so let's move on to the next one. Next one is IgA deficiency. So remember, IgA is a antibody which is found both in blood and also in secretions, in your respiratory secretions, in your GI secretions, even in breast milk. So whenever it is in the blood, it's actually two IgA molecules. So two molecules forming or join in the center with something called a J chain. So J chain actually joins up two Fc region or fixed region of two antibodies and forms a IgA. And this IgA, whenever they are secreted in the secreted in the GI tract or in the respiratory tract, they get something extra which is called a secretory piece. So that's the basic idea. So IgA in the respiratory or GI mucosa actually protects you from infection, and one of the common infection which it protects from is infection viruses. So IgA actually traps the viruses or traps the bacteria and do not let the bacteria or viruses to enter or to invade through the mucosa. And one of the most common diseases whenever you have IgA deficiency is you have upper and lower respiratory infection, and also you have giardiasis in the intestine. And whenever someone has IgA deficiency, commonly they tend to get anaphylaxis following blood transfusion, and the mechanism is pretty amazing. So suppose one patient is IgA deficient. It's totally IgA deficient. There is no IgA. So his or her immune system does not know IgA. What is IgA? I don't know IgA. I have never seen IgA. So it's foreign. So whenever he or she gets a blood transfusion, and this always blood always contains all those materials, one of the material is IgA. So if someone is IgA deficient and now he gets a blood donation from another person who receives the blood, now this blood contains IgA, and the patient's immune system has never seen IgA. So whenever the IgA comes to the patient's body, now the immune system goes, I have never seen you. Who are you? I'm gonna kill you. And this leads to a severe allergic anaphylactic response. And this is a classic feature in IgA deficiency. And this might lead to acute chest syndrome, and in severe cases it can lead to death. Next, we have the anterior cruciate ligament injury. So anterior cruciate ligament is the ligament that attaches your femur with the tibia. So you have the femoral condyles, two condyles, the lateral condyle and the medial condyle, and the anterior cruciate ligament is actually attached with the lateral condyle of the femur, and then it attaches with the tibia, and it helps to protect the tibia and fibula from anterior displacement. So the tibia is held in place, so it cannot glide anteriorly. So whenever you have injury of this anterior cruciate ligament due to any sports accident, this will lead to a positive anterior dry sign, which means that if you fix the femur and if you pull out the tibia anteriorly, the tibia will be coming in. So tibia will be so lax that it will come in anteriorly a bit more than normal. Okay, that's all about anterior dry sign. And remember the posterior cruciate ligament injury? Yeah. So posterior cruciate ligament comes off from the medial condyle of the femur and attaches on the posterior part of the tibia, which is also known as posterior part of the tibia. Just remember that. And this prevents the tibia to go back. So it prevents a backward or a posterior displacement of the tibia. And whenever you have damage of posterior cruciate ligament, you will have a posterior laxity of the tibia. So if you fix the femur and if you press on the tibia, now the tibia will be going backwards more than normal. So it will lax in the backward direction. So it will be called a positive posterior dry sign. Okay, that's about the cruciate ligaments. Next, you have Marfan syndrome. So Marfan syndrome is a disease, a genetic disease. You have a genetic mutation which leads to defect in fibrillin. So fibrillin is a scaffolding protein in the extracellular space for elastin. So if the fibrillin cannot protect the elastin, the extracellular space now becomes lax or weaker. And if you have a weak extracellular space, the tissues that rely on the strength of extracellular space for their proper function now will be non-functional, dysfunctional. Suppose lens, and lens has those jonular fibers, and those jonular fibers contain fibrillin. And if those jonular fibers does not have enough fibrillin, or the fibrillin is abnormal, now the jonular fibers will be weak, and sometimes they are so weak that the lens actually gets out from their control. So there is lens dislocation, and commonly the dislocation is upwards. Okay, always remember, the Marfan syndrome patients are long patients, and their lens dislocation is upwards. In case of homocystinuria, you have a downward and medial dislocation of lens. Very important to remember. Okay, and another problem is they have arachnodactyly, something like that, goes like that. If you have a decreased activity of elastin, now the elasticity is reduced, so your limbs tend to grow longer. So there are long fingers, long hands, long upper limbs, long lower limbs. So one common example is given is their arm to height ratio increases, their lower body to upper body ratio also increases because their legs are so long. Okay, and long fingers are also known as arachnodactyly, like of creepy fingers of I think out of a Spider-Man movie. So they have this creepy long fingers. I mean, I don't know what's that. Okay, next, aortic dissection. First of all, aorta is a very high pressure system. So it pumps blood from your heart to the tissues, and that's why this channel is in so much pressure. If the extracellular space or ECM, extracellular matrix, is weak due to a defect in fibrillin, now there will be degeneration of the extracellular space, or degeneration of especially the aortic media, also known as cystic medial degeneration of the aorta, because there is defect in fibrillin. So now those tissues are very weak, so there is degeneration, which will lead to weakening of the aortic area, or aortic weakening of the aortic wall, and this can lead to aortic dissection or even aortic aneurysm. And aortic dissection commonly presents with severe chest pain that radiates to back, and you have this hypotension and also tachycardia. And also you have hyperflexible joints, because if the fibrillin cannot protect the elastin, now elastin cannot work. So the joints will be very lax. So you lose the elasticity of the joint, simply saying that. Okay, so that's the Marfan syndrome. Okay. Next, we have secondary polycythemia, athlete with polycythemia, which occurs due to secondary erythropoietin injection. That's an interesting thing. First of all, your RBCs carry oxygen. If the amount of RBCs is increased, the amount of oxygen the blood can carry, or the oxygen carrying capacity, will also be increased. And athletes do this specific physiological treatment. Okay, so they tend to inject erythropoietin, and this erythropoietin increases their RBC mass, which will actually improve their circulation by improving oxygen delivery to their muscles when they're exercising, high stress exercising. And that's all. That's about it. That's the secondary polycythemia due to erythropoietin injection. Next, if you have some patient with Pott's disease, which is tuberculosis of the vertebra, whenever you have tuberculosis of the vertebra, it's an infection, right? Whenever you have infection, this will cause fever. So the patient commonly has fever, and tuberculosis infection is commonly a prolonged infection. So the fever tend to be for a prolonged duration of time. And whenever you have inflammation of the vertebra due to tuberculosis in the vertebra, especially in the intervertebral areas, it will lead to back pain. And tuberculosis infection is commonly associated with night sweat, which is kind of a knee jerk for TB infection. Another disease which is also commonly associated with night sweat is lymphoma. So whenever you have lymphoma, there is something called a B symptom, and one of the B symptoms is drenching night sweat, okay, which is a very bad sign or ominous sign. Okay, so that's all from me for those typical diseases. Thanks to all for watching my video, and I'll be coming back with the later important diagnostic clues and their explanations. Okay.